Carolyn and Dr. Edwards are presenting.
Like this story. Just because you wrote it.
It's official. It's official. All right. So I'm Carolyn. If you don't know me, I'm an orthopedic physician assistant at Summit Brain, Spine, and Orthopedics, working with Dr. Gary Edwards. So today we're talking about orthopedic emergencies. Do you want to come sit? Brandy, this is for you right here. We're going to talk about orthopedic emergencies. So because he's here, you know there's going to be really good stories. You can look forward to seeing some pretty graphic / awesome orthopedic pictures up there.
Your discretion is definitely advised.
It is. Best. Hopefully no one gets grossed out by stuff. And hopefully you learn a little something along the way. I hope that you leave this rounds with understanding a little bit more about why some of these injuries or situations have to be identified quickly and addressed rapidly. So we're going to get into it. We're going to get into it with a case study. We get a call from a nearby emergency department, and the history is that there's a 23-year-old man who's there with arm pain. The report is that his arm pain is severe, that refractory to pain medications not really helping him at all. And then by way of other recent history, the patient was helping a friend move a mattress 3 or 4 days before. And when he was like heaving the mattress into the dumpster, he felt something poke his arm. He thought it was a spring from the mattress. And they were like, yeah, you got to come see this guy. Something's going on. Thoughts?
Is it bleeding?
No, it is not bleeding. But you're going to see some blood. That was so good, Amelia. All right. Other thoughts? Yeah.
I'd say probably infection in maybe the fascia or the tendon.
Great thought. Yeah. Other thoughts?
Does he have an open wound?
He does not.
Poking, so he doesn't.
He just has no openings.
A little, like you can see a little poke hole.
So there is like a little puncture.
Yeah,
Alright.
but like
That changes my thought on tendons.
Is it all swollen?
Very.
Yeah.
What do you guys think it is?
Gross.
Gross.
Yeah.
Gross. This would be the intelligent answer.
Sir, you nasty. So yes, we heard the answer over here. It's the thing that makes us immediately concerned by this story is compartment syndrome. Okay, so let's talk a little bit about compartment syndrome. We're going to start off with a couple pictures. So treatment for compartment syndrome, we're jumping to that and then we're going to go backwards. How do we treat compartment syndrome? Fasciotomy, yes. So we got to the ER. This patient's arm was double the size of the other arm. It was rock hard, exquisitely painful. And when I'm trying to paint a picture, like walk in the room and the guy is writhing on the stretcher, like, right?
Well, I've been told patients are writhing in pain. Like, I hear that all the time, and I walk in and they're eating Burger King.
Doritos.
And they're like, yeah, it's 10 out of 10. And I'm like, what is 10 out of 10, the Burger King or your pain? But, because it's not the Burger King for sure. No, but this guy, like, literally writhing in pain, like screaming in pain in the emergency department.
Despite Dilaudid, and so, a couple doses of that's not helping. So, there you go. So what this doesn't show really well is what the tissues looked like when we first got in there. I wish we'd taken a picture of the tissues. The tissues looked like gray fish, right? Like dead fish, like just gray, dead tissue. It's the first one I've done in surgery with you, so some years ago, and I remember like rongering, like you were rongering out all of this dead tissue, and I was thinking like, what's going to be left of this arm? But there was, some stuff. There's some stuff left, but there was so much dead tissue. So there's so much swelling in this compartment that challenge is to close it, right? And it cannot be closed straight away. It can be partially closed. This is kind of what that looks like in phases. So
the fascia here is released farther than the skin incision. So rather than making a skin incision along the hole. The dorsal compartment wasn't involved, the mobile wad wasn't involved, the hand wasn't involved. And so our skin incision is here, but we kind of push, cut, release the fascia like a little bit more distally than the skin incision shows and a little bit more proximally. So here we've just closed the skin. We haven't closed the fascia there because once we released the fascia and got rid of, he had a little infection there that was spreading so rapidly that the swelling caused compartment syndrome. And so he's like effectively immediately treated. And so now our focus shifts to how the heck do we get this thing closed over time without having to take him to the OR 4 times, right? So this is one of the techniques we have. So we take a little vessel loop and we weave it in the staples, and then this can just be tied and untied. So slowly, like on the floor, just pack him with wet to dries, and on the floor we just, every day, just a little cinch and bringing it closer and closer together. And
until it's close enough and the pressure's, like the swelling's down enough that then you can go in and definitively close it.
Yeah, and this also, if he continues to swell, is a good strategy because the floor can just untie it. And then it can just, swell forever, I guess. Yeah.
I know this comes to surprise, but I had this in my leg. And I just have a quick question because I have a portion that's like indented. Do you remove some of that dead tissue?
Yeah.
If it is dead?
Yeah.
How do you choose? Obviously it's the dead tissue that you remove. Mostly you take a little rongeur or a curette or something to scrape it, and healthy tissue doesn't get removed by like scraping it. And so the appearance of the tissue, like the necrotic dead tissue is like gray or dark or looked, not anatomic or not like a normal fascia does. And so we're scraping at some of that and just kind of pulling, and the loose, like dead necrotic tissue just comes, and then, wash it out and then kind of re-scrape. And then once you get to like a bleeding surface, you're at healthy, viable tissue. So that's effectively the strategy. Avoid major tendons and nerves, avoid the radial ulnar artery, scrape at the tissue, scrape at the muscle until you're pretty confident you're getting a bleeding surface everywhere. And yeah, the indentation's probably from a little fascial defect that like you just had to cut it away because it's dead.
So I didn't mention this initially. This is acute compartment syndrome. There's chronic compartment syndrome, different issue for another day. But acute compartment syndrome is treated differently. So let's talk a little bit kind of about what it is. So I'm just gonna hit all of these. So if you don't know that much or don't remember anatomy super well, you have these muscle compartments in your body, and the muscle compartments have fascia around it. The fascia is like this fibrous substance that is actually in the OR, it's like very strong, like a tiny fiber holding on, like ruins your day.
Well, we had it, when we do our ACLs, we do an all-inside technique. So we have to parallel park it. So we go dock the ACL in the femur, and then we pull it from out the portal inside the knee and then down into the tibia. And so because there's no hole through the cortex of the tibia or the femur, you have to kind of, and one day we did get the ACL, like the suture attached to the ACL caught on a string of the fascia that was a fourth the like width of our like suture, and like it didn't matter how hard we pulled it, we could not pull it back through. So we had to go like find it, and then just like it was like a little scissor snip, and then suddenly the whole thing, like it's crazy strong.
Oh my gosh, good job. We didn't even say that on purpose.
We practiced last night like 4 times.
That was so good, you guys. All right. So the fascia has doesn't have much ability to accommodate for this rapid swelling. And so effectively, you get this space, you get intense pressure swelling around these structures, very quick death to the muscles, nerves, and blood vessels. So very big deal. Where do we have compartments? Where does compartment syndrome occur?
Forearm, good.
Forearm, yes. Leg, yes. Where is it most common?
Lower leg.
Leg.
Kick accidents or concussion.
Yep, and we'll get to some of that, but yes, legs most common. I have seen this in the emergency department in other places. I've seen it abdominal compartment syndrome, very quick bowel death, ended up with a total colectomy. And that was from chronic constipation, abdominal compartment syndrome. Yeah, impressive. I've seen, you can have it in fingers, buttocks, like it can be everywhere, but most commonly in most, I would say, right, or we see it most in, or we see most emergency rooms worried about it, I would say, in legs and arms and calling us about that. Yeah, so, oh no. So this is kind of a cross section so that you can get an idea a little bit about where the compartments might be just for the lower leg, right? So Dr. Edwards was initially talking a little bit about compartments. I don't know if you got that for the arm. So these are some of the common compartments, but there's others in the body that can get compartment syndrome. These are most common, here. So why does it happen? Why do we get this compartment syndrome? Amelia, yes, infection, you got it. Infection. Why else would we get compartment syndrome?
Fractures.
Yeah. Yep.
Fractures,
Yes.
excessive bleeding, anything that swelling inside that compartment.
Yep. Great. Other things.
Blunt force trauma without fracture.
Soft tissue injuries. Yep.
I was waiting for Brad, but overuse injuries sometimes, especially in the lower, like just continuous overuse, overstress that muscle, and again that fascia can't accommodate, so then we have compression.
Yeah, that is a typical picture for a chronic compartment syndrome, and then like kind of as you stop your activity, things get better, right? Acute compartment syndrome, it doesn't. So other things, burns are really a big cause of compartment syndrome. You could put a splint or a cast on too tight, and that can cause compartment syndrome. Surgery. Yeah, can cause it. And
Question for you about the case, the spring.
Mm-hmm.
What was it with the spring? Was that
the spring, right? Like we don't know. I actually thought this could probably my downtown Atlanta training. I was like, it was a needle, like in the mattress. Like I don't, right? Like we don't know. He said something poked me. It must have been a spring, but no one really knows like what it was that poked him or why it caused that, right?
But you would have thought of that as some sort of.
He grew out group A strep from the wound.
Yeah.
So it was probably an early like necrotizing fasciitis that led to like compartment syndrome, and because his like necrotizing fasciitis picture wasn't that advanced. It wasn't like, crepitus all the way up his arm, and so group A strep grew from the wound, which is a super common cause of necrotizing fasciitis.
So something over it.
The obvious takeaway is don't help your friends move.
Obviously.
That was my takeaway. I'm not carrying your mattress, bro. Ew. Yeah.
So my fascia or my compartment syndrome developed after they did an ORIF on my leg, so it was a fracture.
Yeah.
Do you typically externally fixate these nails to avoid compartment syndrome from the surgery?
Yeah, if compartment syndrome or if the amount of swelling is a concern, then yeah, you externally fixate. If you're already that swollen, then you can put on an X-fix and do the fasciotomies. And so really, and I think this is kind of the next step, you can evaluate the pressure in the compartment by using a Stryker needle, but really the compartment syndrome is a clinical diagnosis for the most part. And so if it's something where you're already that swollen, you do fasciotomies just right away, and then X-fix, and then get wound coverage, and then worry about the fracture.
The Stryker needles sort of like help.
Yeah.
Well, I think
we'll go talk about that for a quick second. When we have like gone to the ER and there's a patient who they say we're really worried about compartment syndrome, like you have to check it. Literally, this guy was eating Doritos. He'd had a lawnmower roll over on him. His leg hurt. No brakes. Ultrasound negative. Eating Doritos. And we were like, this dude does not, like, he does not have compartment syndrome. The guy who was writhing around screaming, nothing could, his tissues looked like dying, right? So they were like, no, we just like, let's striker it, right? So we'll show a picture of that. But what that is like a syringe that's like pre-filled syringe, has saline in it. You inject it, that goes into a little box, and the box has the ability to read the pressure, right? So you put this into the patient in the compartment that you're worried about. You inject 0.3 mils of saline, and then a magic number comes up on the box. And if that magic number, it's like eye pressures too, you're like, it's a random number generator. But if this random number generator is above 30, you have a higher suspicion or concern for compartment syndrome. And if you take the diastolic blood pressure and subtract the number and it's below 30, then you also are worried about compartment syndrome. We were talking about this yesterday, or I don't know, a week ago or so, but there are some times where you would choose to do the striker pressures if maybe they had dementia and couldn't really give you a good history, or they were really young, right? So there are some situations that, other ones you can think of?
Intubated in the ICU.
Yeah.
Or like
Yeah.
mental status
I try to get my hand up quicker before you change the slide, but one thing I think is relevant to when you're thinking about causes of compartment syndrome. The one that Dr. Hoffman and I had was a guy who was on Eliquis and chose not to be compliant with how often he took his Eliquis, and was taking it way too much.
Mm-hmm.
And it was the compartment syndrome came from just a simple fall where he landed on his leg, on his arms, because he had too much Eliquis in his system and internal bleeding in his. So there could be secondary symptoms as opposed to just these regular things that you're thinking about. If a person's on some kind of anticoagulation therapy, that could be an alarm in the back of your head. Ooh, maybe I should consider that.
Yeah, for sure. In my experience, it's not subtle.
We had one, it was a bodybuilder that was on steroids, and he ripped his pec muscle, not the tendon. So he ripped his whole pec muscle, and then he developed compartment syndrome in his chest because he was just effectively bleeding into his chest. So yeah, bleeding definitely. Is it bleeding? It's a great question.
All right, so signs and symptoms. Number one, pain out of proportion with what you're seeing. I mean, the arm was swollen, but the response was very impressive. Swelling, numbness, pulseless. By the time you hear you have no pulse, and it's very pale. Like that's really advanced, and you'd like to not get to that stage. So this is the striker device that we were chatting about and kind of how it works. This is where the readout is.
Magic number.
Yeah, magic number generator. It's right there. And you trust in that. Yeah, so any other questions about compartment syndrome?
I'm wondering about people who are chronically sedentary and they get accumulation of those dependent limbs. Does that be like, for instance, I've had a couple patients who have had oozing. The legs are leaking,
Mm-hmm.
and is that, to me, that's a potential setup at least for infection. But have you ever seen compartmental syndrome from that?
I haven't.
I haven't.
It's more in the superficial tissues.
Yeah.
Not deep compartments. Yeah. Haven't seen that yet, but yeah, for sure, they're at risk for infection when they're so swollen it's just leaking out. Yeah, for sure. Next one.
Should we do the next one, or should we do the next one?
Yeah, we'll do the
Because the next one's yours, and then the next one's mine. So let's just skip that one.
All right, we'll come back to that. This is not normal.
It's also bleeding. All right, so this is a 17-year-old kid that was a passenger with his friend driving, and they got into an accident, and he braced himself on the dashboard, and he's also writhing in pain. But get called and, hey, got a 17-year-old kid here, and then you get this picture. Mm-hmm. So, what are you doing?
Transferring to the U.
No, to Summit Brain Spine Orthopedics. To Dr. Edwards.
No, yeah, transfer to the U. Don't call me. If I'm not on call, don't call me about this. Sure, we'll see him in clinic in 4 days.
What are you going to ask straight away? Like the ER sends you this picture, or someone calls you and says the bone is sticking out of the skin. What pertinent questions do you want to know straight away?
Which bone?
It's critical.
Is neurovascular intact or not?
Yes.
Yeah.
Yep.
Yeah. Super important. What else? Like, what do you want to do here?
You're like,
it?
call
Sure.
orthopedic surgery immediately.
Sure. You're on your way in to fix it. What are you telling the emergency department to do? Don't let him eat. That's good. What was that?
Prep for surgery has to be reduced.
Yeah. So this is big risk here with open fracture is an infection, and so that the end of that bone is sticking out with just any opportunity to get infected. So I'm telling them, try as best you can to get the bone inside the skin, wash it out as soon as you can. So yeah, good.
And give them antibiotics.
Yes. Tetanus, all the things.
This
So
is
this
that same one.
This is that same picture. So you can see, and they called me. I was like, try to get it back in the skin, and they called me back 25 minutes later as I'm like arriving. They're like, we can't, and I'm like, don't worry, we're going like right now. So we rolled back, and I found out why they couldn't, because even with our open incision here, like we couldn't for like 40 minutes he just was like perched here, and like we could not get it like back over the top. So we had to we opened up the ulnar side, we made our standard volar approach, and then we had to go underneath the tendons, underneath the median nerve, and then just like pull it out, and then we finally got it back out to length. And then he's 17. The growth plate was a little bit still open. He's probably for the most part done growing at his distal radius, but just in case, normally you'd have the plate like up here by the watershed area, but we put the plate a little bit lower and just pinned through the growth plate just in case he had quite a bit of like growing left, and then we plated his ulna. But yeah, it
looks real good.
It looks real good.
Okay, so briefly, what makes the fracture an emergency? I just love that so much. I thought it was broken. So open, impending open. What does impending open mean? It means like the skin is tented, right? We've seen like dimple signs. We'll show you that in a slide or two. Clavicles pretty commonly where it's like nearly poking out of the skin. You're like one wrong move, right? So that also makes it an emergency. Neurovascular injury, so many stories about that. Suspected compartment syndrome, dislocations, or significant displacement. It's a good story, you guys.
So this is normally a proximal humerus fracture is like not an urgency or emergency, and I get a call about a proximal humerus fracture. I'm like, yeah, sling, and like we'll follow up in clinic. And I got a call about this patient, and she tripped and she fell against a wall, and they're like, yeah, it's a proximal humerus fracture. I mean, this is at like 11 o'clock at night. I can't see the picture. They're like, it's a proximal humerus fracture, and she has some numbness and tingling in her hand. And I'm like, well, like, okay, how are her pulses? Oh, I don't know. let me check. So went and checked, and they're like, yeah, they feel really pretty weak compared to the other side. And I'm like, okay, get a CTA. Is that our next slide?
Yeah, and then for like description purposes, right? This is the humeral head, and that's the glenoid. Should be like there.
Not
and
great.
And then a lot of comminution.
Yeah, really pretty displaced. And then we got a CTA. Well, this is on the CT. Yeah. This is the brachial artery here. And then that is that bone fragment here. So this bone fragment was abutting the brachial artery.
And then there's our CT. So you can see brachial artery, pretty good flow, and then down to like around 50% of the volume. And so by the time they got the CT, they called me back and they're like, now she can't like move her hand at all. And she's really numb. So what do you do? Send it to the U. No, an impending injury like that, transfer isn't really an option, because if you take 8 hours to get an accepting doc at a different facility and do all of that, like you're in huge trouble. So what do you do?
Get out of bed and go fix it.
Yeah, fair. So one of the issues is the fix for this is a shoulder replacement with the proximal humerus that destroyed, and there wasn't a reverse total shoulder isn't really an emergency case. Sometimes we do like hip fractures or hip replacements for a femoral neck fracture. So almost all the hospital systems have a total hip system like ready to go. Well, the same isn't true for a total shoulder system. So we were 4 hours away from the instrumentation being ready to do a reverse. And so our options were, cut it open, relieve the compression of the artery, hope artery doesn't explode, and then close it up, come back the next day. Or what we did is I just went and gently closed reduced it. So we sedated her and I just gently pulled her arm down, and then immediately like the radial pulse came to full. And so we had her sit in a sling with Q 5-second neurovascular checks while we waited for the instrumentation to be finished. And then we fixed it, put in a reverse total shoulder. So the whole healing of the reverse total shoulders is the tuberosity. So that's the tuberosity, the lesser tuberosity with the subscap, and then that's our greater tuberosity there that we pulled over. We actually fasten it into the stem. So we try to pull it down. The tuberosity healing is kind of critical here. But when we got down, like when we dissected it, that like bone had like migrated back to that spot on the artery. So we had to just kind of gently release it. And again, hopefully it didn't.
And that was like actually like indented.
Yeah.
Like you could see the scary, kind of scary, but.
So kind of a proximal humerus is like one of those, when you intern in Chicago, I'm like, oh, hey, I got a call about a proximal humerus. And it's like, oh, that's the easiest call you'll get. This is what a fifth year told me when I was an intern. That's the easiest call you get. It's just a sling and follow-up outpatient every time.
Did you call him back?
Until it's not. I was like, hey, bro. Note.
Not every time.
Not every time. So that's why some of the little like subtle findings or physical exam things are just being keyed into like, hey, maybe what's different about this then, and it's just like, it was just said to me that the patient had some numbness in their hand. And then that was like, okay, like, does she have, you just have to run through the whole history now. Does she have carpal tunnel? And this is just her carpal tunnel symptoms, right? So we have to then just like, well, hold on, back up, step back. Like we got to go through the whole thing and then get the CTA. And then lo and behold, we found out why, so.
Yep. Those were the couple examples of tenting that I was mentioning. This is the patient's head is here. This is the clavicle.
Looks like a giant
it's
rocket.
like, yeah, I know it does. And then this was a fracture dislocation of the ankle in the ER. That's always concerning when you see the skin doing that quickly. The pressure on the skin causes like neurovascular injury, and wounds pop up really quickly with those. So reduction of that is urgent. All right, that's all the time we have. Thanks, y'all.